Hey, it is my pleasure to introduce Dr. Ursula White. She's an associate professor at the Pennington Biomedical Research Center. She holds a PhD in biological sciences from Louisiana State University and is a renowned expert in the field of adipose tissue metabolism and its impact on metabolic health. Dr. White's research focuses on understanding the dynamics of adipose tissue expansion, remodeling, and metabolism, particularly in relation to energy balance and its role in the pathology of obesity-associated health outcomes. She's the Associate Director of the Human Phenotyping Core for the Nutrition Obesity Research Center. She's received or successfully secured substantial NIH funding for her work, including a pending R01 with an excellent score.
Yes.
Yeah, excellent. Her accolades include being named a diversity scholar at Harvard North, being named an early mid-career scholar in diversity, equity, and inclusion by the Trans-North DEI Executive Committee, and receiving a Leadership Institute Fellowship from the Society of Behavioral Medicine. Dr. White's extensive publication record includes high-impact articles on adipose tissue function in health and disease. Additionally, she plays a significant role in the professional community, notably as past chair of the annual program committee for the Obesity Society and as a reviewer for various NIH study sections. In addition to that, Dr. Ursula White is actively involved in community service, prominently within organizations focused on health and empowerment for women and minorities. She serves as a mentor in the Unapologetically Be the 100 Mentoring Program under the National Coalition of 100 Black Women, and her efforts and impact were recognized in a feature by 225 magazine titled Women Making an Impact in 2022, highlighting her significant contributions to her field and community. Please join me in welcoming Dr. White today.
Can I have a copy of that and like frame it or something? That was awesome. I appreciate this invitation. I've had some excellent meetings with everybody today, so I'm really excited to give this presentation and get your feedback. Special thanks to Catherine, who invited me some time ago and who saw me at the Obesity Society meeting while we're in passing and stopped and was like, oh, hey, Ursula, it's me, Catherine. See you in April. And I was like, yes, you will. I'll be there. So I appreciate the opportunity and I'm excited to visit. So I'm going to talk a little bit about some of my work today. I'm going to try to just be as concise as possible and give snapshots because I love the opportunity to engage in questions and discussion at the end. So I'm going to talk about a few of my in-progress studies, including some R01s and also some funding from a lipedema foundation, as well as a recent grant submission of an R01. Okay, so I won't go into detail on this introduction because I'm familiar with my audience, and so I know this diagram is very familiar, this concept of energy balance, which is a balance of energy intake and energy expenditure, and we understand the importance of energy balance in modulating body weight or weight control. And so this concept is particularly important and also heavily influenced, I would say, but even though I'm biased, by the adipose tissue. And so we know that adipose tissue has various characteristics. There's been a lot of advancement in the field of adipose tissue research in recent years, but we know fundamentally adipose tissue is the primary storage site of energy. So it would stand to reason that the role of this adipose tissue in energy balance in health and disease is of importance. So we know that if there's higher intake we know that the adipose tissue can expand and accommodate the excess energy. That's one of its characteristics. And we also know that it's very plastic in function also. So if there's more energy expenditure or more calorie burn as relates to, or in comparison to energy intake, that the adipose tissue can even decrease in size. What we don't fully understand are the dynamics of these changes in expansion of the adipose tissue and the reduction, and some of the adaptations that can occur during these changes in balance, in energy balance. They remain, not well understood. And so how does energy balance relate to health and disease? Well, we know that obesity is a disease that is characterized by excess adipose tissue. So the function of the adipose tissue, whether it's in excess, whether it's changing during energy balance, et cetera, all of these processes can heavily influence the pathophysiology of obesity as well as other related metabolic diseases, including cardiovascular disease, type 2 diabetes, hypertension, pick your poison, all of the above. Okay, so what are some fundamental questions that I kind of asked, in my journey as relates to energy balance and health? So, what are the physiological changes that occur during these changes in energy balance? And I'm speaking in terms of weight gain and weight loss. So, if we think about how practical this idea or concept is, we know the term weight cycling has been around for a long time, right? But the jury is still out in terms of the impacts of weight cycling on metabolic health. So, what are the adaptations that occur not only from an overall physiology or systemic standpoint, but also in the adipose tissue? What happens during these fluctuations in energy balance? How do they impact short-term health as well as more long-term health and function? So that leads me to the next point. How do these changes influence and or predict obesity related health outcomes? So these are kind of the focuses. And also, what is the role of the adipose tissue? I hope I've convinced you. Well, you don't need my convincing because of the work that you do here, but I hope I've made a point that studying the adipose tissue, especially in this context, is extremely important. So let's talk a little bit about the fundamental aspects of adipose tissue expansion. So we know that adipose can expand via hypertrophy or hyperplasia. So in layman's terms, hypertrophy is the expansion or increase in the adipocyte size of existing adipocytes. Hyperplasia is the increase in number or also the proliferation of pre-adipocytes that can go on to form adipocytes. And there's so many other processes involved in this. It's not as simple as this diagram, but that I just wanted to provide a little snapshot of that because it relates to an approach that we're using in our studies. So why is the expansion of adipose tissue important? Well, it's been known for a number of years that adipose tissue expandability, its ability to expand, right, and accommodate lipid and the functions that happen thereafter can impact metabolic health. So this is a review that I pulled from some time ago, but it just demonstrates kind of a general snapshot of the adipose tissue expandability hypothesis, which is pretty common in the field. So you have neutral energy balance there where you have an assortment, right, of large cells and small cells. You have healthy hypertrophy, healthy hyperplasia. Even during times of adipose tissue expansion, during positive energy balance or excess calories, as long as the adipose tissue can safely expand via hypertrophy and hyperplasia, increased size and number, that the lipid can be safely stored in the adipose tissue, right? So this is one of the primary functions of the adipose tissue, to be able to make sure that lipids go to the adipose tissue and not other places like the liver and the heart and places that are not as metabolically beneficial. And so if this happens, metabolic homeostasis is maintained. However, if there are limits in adipose tissue expansion for a variety of reasons and factors, during times of chronic positive energy balance, that means over the long term, especially as seen in the disease of obesity, you can have lipid spillover into other tissues that are not the adipose tissue, ectopic lipid accumulation. This disrupts the adipokine profile, and then there's metabolic disruption. So one of the points about this adipose tissue expandability hypothesis is that the role of hyperplasia has been kind of a high point. So the thought was that as long as you can have successful hyperplasia and make more fat cells, then you will remain healthy, or it protects you from some of those metabolic impairments that can be seen in obesity. So enter, this is my first RO1 that I proposed, and originally we were basing it on preliminary data, which I'll show shortly, and it was heavily focused on the physiological changes that happen during weight gain or doing overfeeding. As you see, that's only a snapshot of this actual grant. It's actually much more comprehensive than that. I was super excited. It was funded in February of 2020, and I called everybody and I was ecstatic. And then in March, the world shut down. So anyway, needless to say, it's been a challenge, but I think it's a very exciting study. So I'm happy that it's still ongoing. I want to revisit this adipose tissue expansion diagram because I want to point out that part of the innovation and novelty of this grant is the fact that we're doing this approach. It's an in vivo labeling approach to assess adipose function, specifically adipose turnover. So when I say adipose turnover or adipocyte turnover, we're able to measure adipocyte hyperplasia, which previously has not been shown, right? So what can we do using this innovative method? We can apply it to intervention and we're able to truly assess adipose expandability, right? So that's the only way you can really test mechanisms of fat expansion is to perturb the system to promote expansion. So the way that it works, it uses a stable isotope deuterium, not radioactive. It's stable isotope, and so participants can drink the water. And this has been around for years. It's been used in the elderly and pregnant women, etc. So very tolerable and safe. And participants drink the water over the course of 8 weeks. The deuterium becomes enriched in the body water. In turn, the deuterium also becomes enriched in other cell types in the body. So you could collect blood, you could collect skeletal muscle, you could collect all sorts of cells. Obviously, I'm interested in the functions of adipose, so we collect the adipose tissue, and we're able to get measures of formation over the course of the intervention time. So that was part of the novelty, and you'll see this specific protocol implemented in other studies as well. Okay, so this was one of the initial studies where we utilized this deuterium labeling approach. So it was, ladies, how does body shape affect your health? It is looking at body fat and body shape. So it's not studying the effects of eating apples and pears, which a lot of people did call our clinic asking if that's what it was about, and it was not. It was this idea that we know, especially in women, there can be different fat distributions. So individuals that have more fat in the abdominal region are very different physiologically than individuals that have more fat storage in their lower region. So this was a study to try to understand that. Okay, so we recruited apple and pear shaped women. We used the deuterium labeling approach over the course of 8 weeks. There's our distribution of subjects by race. There's the characteristics of age and BMI and percent body fat. And then after the screening and enrollment in the 8-week intervention at the testing period, we did the traditional body composition assessment. So we did DEXA and MRI. And for this study, we did the oral glucose tolerance test to assess glucose tolerance. So we did have endpoints for that. And then mean blood pressure, things of that nature also. Okay, so I'm not going to go into a whole lot of in-depth detail on the data, but this is published. And so what we found was very interesting because remember previously I mentioned this concept in the adipose expandability hypothesis, where if you can make more fat cells, then it can protect you from impaired health. And so you would expect, or we hypothesize, that individuals that made more fat cells would have been more healthy. Actually, we found the exact opposite. So technically, this was a cross-sectional study. It was not intervention. So you have to keep that in mind. However, when we looked at correlations of higher fat cell formation with visceral fat, insulin sensitivity, and even the number of metabolic syndrome risk factors, we saw the complete opposite. So individuals that actually made more fat cells and had more hyperplasia actually had more impaired health outcomes versus those that had less fat cell formation. So this was an interesting observation. And again, this provided some preliminary data and rationale to really study the dynamics of fat expansion because it's obvious that we're not getting the whole story, right? And so there's room, for advancement in that particular area. And so what we found after looking through the literature, that our observation was not the only one that has kind of challenged this expandability hypothesis in the adipose tissue. There there are other, studies that have kind of seen the same thing, even though there's more. And keeping in mind, these are more indirect assessments, so they didn't use the in vivo labeling approach. They most times, assessed it via fast cell size. However, the observation was the same. Individuals that had more small adipocytes, even though you would expect them to be healthier, they actually were higher in individuals with insulin resistance. And then even during an intervention of overfeeding, individuals that had smaller fat cells at the start actually had a greater decline in insulin sensitivity in response to overfeeding. So this is all to say that it's not set in stone in terms of the adipose expansion and its role. And so again, another thing that we know about fat is that location is important. So you'll see that in this study, as well as others, we're interested in this fat distribution component. And so typically when we collect, adipose tissue for assessments, we collect both the abdominal region and the femoral region, because we know that there are differences between these two depots. Okay, so here's an overall diagram of the E2 study. So it's recruiting men and women between 18 and 42. There's our BMI range, and enrolled participants have to have a fasting blood glucose less than 110 milligrams per deciliter. And so they come in, and in order to, after the screening visit, once they're eligible, in order to really provide the prescription for the overfeeding component of the grant, we do 7-day energy balance via doubly labeled water. Some of you are probably familiar with that protocol. And so after then, we do a testing period 1 where we do the clamp to assess insulin sensitivity. It's a 2-step clamp. We do MRI, MRS, and DEXA, and then we collect adipose tissue biopsies also. And then we also collect, blood samples to do other assessments that we wish to do. So after this testing period, they're actually randomized. So again, in this study, the idea is, again, to perturb the system and to be able to look at changes in energy balance. So for here, we did not provide food. We allowed people to eat whatever they wanted to eat. We just had a prescription in terms of everybody undergoes 30% overfeeding. So when you translate that, it results in about a 5% roughly increase in body weight. So in some people that can be 6 pounds, and some people that can be 8 pounds, just depending on where they start. And so during this phase, they're drinking the deuterium labeled water. So we're able to, at the end of this intervention, we're able to redo the testing period, and we're able to look at various physiological assessments that occur during this time period. And one of which is the adipocyte turnover, among other things. And so, as I mentioned earlier, this part is only a snapshot of the grant. So initially, when we submitted the grant, the idea was to use this deuterium label approach during weight change, which would be increase in weight and weight loss. So we were interested in the whole spectrum. But due to budgetary reasons, and then reviewer comments, we're not doing the deuterium labeling approach during the weight gain and weight loss. However, we still kept the design the same. So the idea is to still look at this weight change over time. And so after the first 8 weeks, they remain in the study. And one thing to note is during those 8 weeks, we send them home with the scale. And so we're able to monitor their weight throughout the trajectory of the throughout the trajectory of the study. So then even during the weight loss provision phase, we keep them linked to a dietitian and nutritionist, depending on whatever their goals are in terms of weight loss during that time. They receive, a certain prescription, how many calories to consume, et cetera, et cetera. We offer them membership, well, not membership, but they can come to our facility to use our exercise testing facility. And so again, for an additional 8 weeks, they're undergoing that weight loss provision. So then after that, they give back the scale. We take that final weight at the end of the weight loss in clinic, and then they're ad libitum, right? So then they're able to go back to whatever their habits were. The idea is that some people are going to remain where they are. Some are probably going to regain, right? Because they're going to be in a different environment. It's not going to be as controlled. And some people may continue to lose. So we expect variability, but we thought it would be extremely interesting to kind of look at more long term, in terms of like 6 months later, how they do physiologically their body weight, but also, other measurements of metabolic health after they've had that kind of weight change, short-term weight change that we've implemented. So it's an ongoing study. And again, this looks like a very complicated figure, but in essence, the idea is that we think, certain individuals are going to respond differently. There's going to be variability in terms of the responses. And the goal is to better understand what predicts those responses. And we think that the adipose tissue, the effects on the adipose tissue and the changes of the adipose tissue during this time are going to influence those metabolic health outcomes.
Can I ask a question?
Yeah.
So this study included individuals with a BMI of 23.
Mm-hmm.
So what was the reasoning behind including that?
23 to 30 to I think 33 or 35 now. Yeah, we've expanded it a little bit. So the collection of the adipose tissue from a person with a BMI of 18 is not gonna happen, especially in the, it depends on how their fat is distributed. So we could have gone lower with the BMI, but we weren't going to be able to collect the fat tissue.
Right. I was thinking like higher maybe because overweight starts after 24, 25. So it's just
Oh, yeah. And that's kind of, where did I get that? Because there was a previous overfeeding study done at Pennington. So I think I utilized kind of the range that was already there and then expanded upon that. But yeah, I definitely just didn't want to go. And I think the range, because they collected fat tissue biopsies in that too. And so I think the lowest that they went and were able to collect the tissue was around the 23 range. So that was kind of the rationale for that. I wanted to make sure, it was a population where I'd be able to actually complete the collection and the assessments. Mm-hmm. Okay, so here's the study progress. Oh, it looks like, oh goodness, this isn't the most up-to-date one. I guess it's a different figure. But anyway, we've actually enrolled 21 people, not 14. So that's great news. But as you can see from our web screener, there has been quite a bit of interest in the study, for a variety of reasons. The inclusion-exclusion criteria, the study demands have been a big thing. So I mentioned some of the metabolic assessments that we're doing, including the clamp. So it's a 2-step clamp, which means they have to come the night before and they have to stay overnight, and then the clamp is like most of the day. And so depending on people's work schedules and things like that, the scheduling gets to be, a bit tricky in that regard. But anyway, we're continuing to plug away in that study. So I'm looking forward to the data that comes out of that. This is one of the promos that we've used. So we actually use an external company. They're not a science company, they're a marketing company, Build Clinical, and they've been very helpful in helping us to recruit for this study. So they come up with these really cute, catchy ads, et cetera. And then they disseminate the flyer through various mechanisms beyond just like Facebook. They have these algorithms that they use that have been extremely helpful for us. But as you can see, and I wanted to point out the portion on the right to see how many interested people we've had. So I think it's been like over 400 people. But if you look at the reasons for exclusion, like for instance, the BMI at 173. So keeping in mind the population in Louisiana, right? We know what the obesity rates are there. A lot of people's BMIs are a little too high relative to what we need. So these are things, just being transparent, when you embark on studies of this nature, you have to be stringent on some things in terms of your inclusion, exclusion, but, these are a byproduct of things that can happen from that. And I just wanted to show an example. This is Kathy. She's one of our interventionists that we use in the study. So I just wanted to show an example of a participant and what it looks like to be enrolled. So this participant was given this map that demonstrates in the blue dotted lines their predicted increase in weight over the course of the 8 weeks. So the participants know ahead of time what's to be expected. They know what's considered within range and what's considered, outside of range. So again, their total weight gain was 7 pounds. So that's kind of the expectation for this particular participant based on her, baseline BMI and the 30% calculation. So you can see this person was, was pretty compliant. She remained, within the lines. And then this is the interesting part, right? So this is the follow-up during the weight loss provision, which you remember I told you we still continue to track the weight. So if you look, this person actually lost almost 15 pounds, which means this person actually went below where they started in terms of their baseline. So, data like this is interesting. And so I think whenever we analyze this data as well as that follow-up assessment, that'll be interesting to see how this person adapted, over time in terms of at that 6-month mark, what happens in terms of their weight and health, and also the assessment of the adipose tissue and the potential role in the adipose tissue in these changes that we're seeing. Okay, so I'm switching gears just a little bit. This is a pilot study with Eric Ravison and I as PI. It was founded by the Lipedema Foundation, and it's focused on the adipose kinetics of lipedema. And we have, co-Is there included on the project as well. Steve Heimsfield, he's very popular in the field of body composition. And so if you're not familiar with lipedema, it's a condition characterized by abnormal deposition of subcutaneous adipose tissue. There's an accumulation of fluid and swelling. It's very painful. Many patients with lipedema also have obesity. So oftentimes the lipedema is misdiagnosed as simply being obesity. And the interesting thing about lipedema is that there is persistent limb enlargement, which means they retain the limb enlargement even after calorie restriction, weight loss, and exercise. So for some reason, this adipose tissue is resistant, quote unquote, in some way to the traditional methods that would normally, increase weight loss or fat tissue loss in traditional obesity. So we have this pilot study, and the goal is to enroll women between 18 to 45. Again, it's a pilot study, and we also pick women because women are the ones who are most affected by this condition. And then BMI less than or equal to 50. And then a clinical diagnosis of lipedema stage 2 or 3. So the other guy that was on that first slide is Vance Alba. He's actually a bariatric surgeon in our Metamor Institute at Pennington. And so when we were first talking about this project, he mentioned, how often he sees lipedema in his patient population. So he's been helpful in terms of recruiting for this study. So again, the objective of this study is very basic and fundamental question, is to examine the characteristics of the adipose tissue and lipedema and compare it to a cohort of women that have traditional obesity. We're actually using the apple pear study, and we'll be able to kind of compare to see how there may be physiological differences between these types of adipose tissue to give us some clue as to the pathogenesis of lipedema. So after the screening, the women, 20 women with lipedema are enrolled. They're undergoing the 8-week deuterium labeling protocol. We collect the fat biopsies, and we also do body imaging. We're using a variety of types of body imaging, because we want thorough assessments, but we also understand that due to the size or weight of some participants, that some, MRI, for instance, may not necessarily be attainable, but we're doing 2D and 3D imaging. So Steve Heimsfield has an excellent setup, where he's able to get these really cool circumference measures and things like that. So we're doing, comprehensive measures of body composition and body imaging in addition to that. And then, of course, blood draw, if we want to kind of look at circulating factors that could be different between the populations. So I just wanted to show this example in terms of the progress. So this was a woman who emailed, and I will say, you know, individuals in this patient in this population are extremely eager to participate, because the other thing is that there is no cure for lipedema, and the treatments are very limited. So again, it's very painful. But again, it's not responsive to exercise. Traditionally, it's not responsive to, you know, exercise, calorie restriction, et cetera. So, you know, what do? You know, and so they're very, very willing to participate, you know, in order to advance the field of lipedema. So this was a lady, she was 48 years of age. So obviously she was not able to participate because she was outside of our age range, but she was diagnosed with stage 2, 3 lipedema. She voluntarily sent these pictures. She's like, look at this. You know, my doctors thought I was crazy. And I'm like, no, something is really, you know, and she's like, no, something is really wrong. But she had been misdiagnosed many times. And, you know, some of it is the fact that some of her, you know, they may just not have been knowledgeable about the field, you know, the field of lipedema, because it's not as advanced, you know, as it could be. So all that to say, some of the recruitment challenges that we've had thus far are age. So the reason why we limited the age range is because our cohort that we're using as a control or comparison, they had an age cutoff. So we kind of wanted to match as best we could. And so that's the reason. But, you know, if we continue to have issues, we may have to, you know, expand, because this project has been continuing for almost 2 years now. The diagnosis of lipedema is another factor that's been a kind of a challenge or barrier. So actually, we've implemented a pre-screen via Zoom or Teams, so that Vance, because Vance is the person on the team who's actually doing the diagnosis, so he can kind of ask questions in advance before they step in the door, you know, at the clinic. Because when you speak to them, you know, via email or over the phone, they swear they haven't, you know, they haven't been diagnosed, and some of them do have it, but others, like for instance, a recent participant came, she was so sure she had it. And we were like, okay, well, that's fine. If you're that sure, you can come on in. So you're like, well, what made you think that you had lipedema? Well, ever since I was small, my daddy told me I had lipedema legs. So I think I have it. But no, actually, you know, she didn't have any pain at the site or anything like that. It was just, especially being a woman, she just had a different body distribution, body fat distribution relative to other people in her family. So anyway, she didn't have it. So all that to say, we get a lot of, you know, screen fails based on that diagnosis of lipedema, and also other inclusion exclusion criteria. Also, weight instability is a big one. So because we're looking at, you know, adipose tissue is a very dynamic organ innately, right? And so if you had recent changes in your, you know, in your body weight, you know, that are substantial, that can be that can be an issue. And so when I say substantial, you know, 20 pounds or so. And why is that important? Well, now because of these obesity medications. So the population that we're looking at, they're in that range, you know, class 2, class 3 obesity, where some of them are utilizing, you know, the tirzepatide and others. And so they're going to have huge differences in their body weight over time, because perhaps they had been taking the drug for a period of time and then they no longer had access to it. And so that's also, you know, kind of been a barrier in terms of our recruitment. But again, we're pushing forward. So it's an exciting study. And then this is another example of a participant that we've had recently. She did enroll in the study and complete the study. We haven't done her physiological assessments, but I'm just showing here, this was, you know, diagrams from Steve's 2D and 3D imaging that he did. So the idea, you know, you can look and you can take all these circumference assessments and things like that. She was an interesting participant because if you look at the lower part of her legs, so she was diagnosed with lipedema in the thigh region, but if you look in the bottom part of her legs, that's actually characteristics of lymphedema, which has a different pathology. So she was interesting in that she had both, but typically we want to avoid lymphedema and focus on lipedema. But yeah, she definitely, you know, was diagnosed with having it in the thigh, so we agreed to include her in the study. Okay, and then to date we've had 10 enrolled, 8 completed, and 1 drop. So we're coming along. We're progressing. So now I want to switch gears just a little bit. to the other part of the energy balance equation, right? And so this was not my study. So if any of the graduate students were present at the lunchtime, they know all about my study that I told them about me and the mice and how we didn't work out. But anyway, this I'm showing a seminal study from Lori Goodyear's group. And this was a study that essentially supported the important role or a novel role for subcutaneous adipose tissue in facilitating exercise-induced improvements in glucose homeostasis. So in a nutshell, what they did, they had an exercise-trained rodent, and then they had a sedentary rodent that was exposed to high-fat diet, so it was overweight and had type 2 or was diabetic. And then they transplanted the subcutaneous adipose tissue from the exercise trained rodent into the sedentary. And in the sedentary rodent, it improved the glucose tolerance, enhanced insulin sensitivity, and it induced substantial white adipose tissue remodeling. So in essence, this just demonstrated or supported, hey, exercise doesn't just affect the skeletal muscle. It also elicits improvements in other tissues, including the adipose tissue. So we decided to investigate that a little bit further. So we completed the study. This was done actually by Tim Allerton, who's an assistant professor at Pennington, where we collaborate quite a bit. And we decided to add like a different spin on the exercise and adipose and focus on adipocyte turnover, which had never been looked at. So we did the deuterium labeling intervention in the rodents during an exercise intervention to assess the adipose or the adipocyte turnover or adipose formation. And what we found, and this is published, was that exercise could decrease adipocyte formation. So it was kind of the opposite of what we thought initially, but not really if you think about it. You don't need to make new fat cells if the ones that you have are efficient. If exercise is having a positive role on your existing ones, then why do you need to make new ones? So anyway, that was kind of what we got from this study, but this is a kind of a preliminary study that we conducted. So then we move forward, and so to a human model, and so this is a collaboration with Lauren Sparks, which it's on the next slide. But we put in this grant to look at the impacts of exercise in humans, in the impacts of endurance exercise in humans. And, obviously we expected, improved skeletal muscle physiology, overall improved cardiometabolic health. But for our interest, we were interested in these beneficial effects on the adipose tissue. So how does the exercise enhance adipose tissue quality, right? So specifically the new adipocyte formation, like does it impair or does it, impair is a bad word, but does it reduce adipocyte formation in humans as we've seen in rodents? And how does it affect triglyceride turnover? Does it increase lipid efficiency, in the adipose tissue to make it more efficient? And so that was kind of our rationale for moving forward with this grant. So this is the Atlas grant, and that's Lauren. She may be familiar. She's a huge adipose tissue person and well known in the exercise physiology field also at TRI, Advent Health in Orlando, Florida. So this was our study, Atlas, looking at adipose tissue in response to endurance training. And so the fundamental question, does exercise improve? And we obviously are doing, the clamp and other assessments to look at overall or systemic insulin sensitivity or systemic health. But for this purpose, it was more focused on the adipose tissue, and does exercise improve WAT-specific insulin resistance? So this is just a general diagram. I know it's a lot of words, but I'll take you through it briefly. So this study is for men and women between the ages of 18 and 45. The BMI between 30 and 50. And so after the screening visit, they would be so it's a randomized control trial. They will be randomized to a control group or either a 12-week endurance training intervention. If anybody is familiar with the MotorPack study, we're kind of mimicking the protocol design for MotorPack. is what we're doing. And so during that 12-week intervention, they're also drinking the deuterium labeled water. And so we're going to be able to get that assessment. In addition, we had a meeting of the mind scientifically because at TRI, they also do a lot of RNA-seq and cell signaling and things like that. And so we're also collecting the adipose tissue to look at some of those endpoints as well. And then we're obviously, going to do body composition. We're also going to do a 2-step clamp, but they're going to be lower doses. So we're going to have one higher dose to look at whole body insulin sensitivity, but also a very low dose to look at the insulin sensitivity specifically in the adipose tissue. And along with that, we're also doing microdialysis to look at blood flow in the abdominal region, and then hood calorimetry to get, an assessment of RMR. And we're going to take the biopsies, obviously, because that's one of our primary endpoint. And so here at the bottom, this is just kind of a description, but this is strictly endurance training, not resistance. And then the goal here is to maintain their body weight. So what we really want to demonstrate is that you can see these benefits, potential beneficial effects, whole body and at the level of the adipose tissue, even without weight loss. So we know that weight loss can, elicit health, but we want to, do it while they're maintaining weight. So they're going to be working closely with interventionists to maintain their weight during the intervention. Okay, so I'll shift a little bit. This is still related to the exercise side of things. So this is a study. The PIs are Bob Hickner, which I mentioned earlier, and Michael Ormsby. So I'm a co-I on this one. This is not my specific study, but I'm involved in this, very much interested in the science, obviously, but I'm involved because we're also doing a component where we're doing the deuterium label method in this protocol also. So the idea of this study is, resistance training modulation of fat metabolism in postmenopausal women with obesity. And actually the women who are postmenopausal are insulin resistant. So I'm excited about this. So you don't have to read all the fine print here because I know it's extremely small, but I just wanted to demonstrate that there was a little bit of shift, between the study being reviewed and getting funded, et cetera, et cetera. So now it's actually going to be a comparison of resistance training versus endurance training. So that's why you see the two arrows going the different ways. And then all of them will within the two groups, individuals will be randomized into an acute exercise group or either a clamp group. So that's a way to assess adipose tissue insulin sensitivity in various ways. So through the clamp is going to be their ability to store adipose, because that's what insulin does. Whereas in response to the exercise, you'd expect the opposite with the lipolysis. So you're kind of able to get a full spectrum of adipose function with resistance training or endurance training exercise. And so again, the objective overall of the grant, compare 12 weeks. And again, they're going to be calorie matched, resistance training versus endurance training on regional and whole body lipolysis. And then this is in postmenopausal women with obesity and prediabetes. So those are the characteristics at the bottom in terms of the inclusion, exclusion. 50 to 70, there's the BMI range, have to be sedentary. And then that's how the prediabetes criteria was estimated. And so then the overall study objective, can endurance, or because you're probably saying, oh, Joy, exercise, like another exercise, like what are you doing differently? And so the idea here, can endurance and or resistance exercise prevent the progression of insulin resistance to type 2 diabetes? That population is very predisposed, at a certain point to the prediabetes manifesting into diabetes. So is it possible, that these effects can be the progression of that, I guess, can be, inhibited or delayed in some way? And can this be mediated through actions that occur in the white adipose tissue? Okay, and finally, I want to talk about this last study. So it's the effects of alcohol consumption on metabolic health outcomes. following weight loss in people with obesity. So that's me, and then that's John Aposin, who's a colleague of mine at Pennington. We work, collaborate quite a bit together. Oh, wait a minute. Okay. All right, so I'll introduce you, before I talk about the R01 proposal, I'll introduce you to the Consume study. So this was our original pilot study that was sponsored, it was funded by our LeCat Center grant. And this was a flyer that we used, right? Because every lady wants to know, can you still drink alcohol while you lose weight? Because if you think about the recommendations, depending on whether it be Weight Watchers or whatever it is, everybody has their or keto diet or whatever, they say, oh, well, you can have weight, some of them you can't have alcohol, or they recommend that you don't. And then in others that you can have alcohol, oh, well, you can have this much, and oh, you can only have this type, et cetera. So we really don't know the impacts of moderate alcohol consumption and if they can mitigate the beneficial effects of weight loss. So that was the reason for our study design. Obviously, we know if you're drinking alcohol and, on top of your normal caloric intake, like if you're, at energy balance and then you add alcohol, the result is going to be weight gain, right? Because now you're in excess in terms of calories. But if we can match the group, macronutrient for macronutrient, we can control it in the sense that the only difference between the two groups is no alcohol or alcohol, and then they're both losing weight. What is it that happens? And so this was published data from a few years ago, and it demonstrated something that we didn't necessarily want, but the data is the data, right? So you can look at the change in blood pressure or the decrease in blood pressure in the control group. Now, keep in mind, both groups lost, there was no significant difference in terms of the weight loss. Both groups lost 7.5% of their body weight. So there were no changes between the loss of the overall percent body fat and then total body fat also. So there was no change in that regard, body weight, I'm sorry. So in regards to that, the only difference again was the alcohol. And so in the control group, they had, substantial decrease or delta in the mean arterial blood pressure. You can see in the alcohol consuming group, they did not exhibit the same decrease in blood pressure. So that was our part of our preliminary data. We also looked at the change in fat mass. So this wasn't significant because again, this was only 12 people, right? 6 and 6, because it was a randomized controlled trial. So given the sample population, in our minds, it was still, a pretty successful and informative study. So again, this data wasn't necessarily significant when you look at the p-value, but it did provide enough preliminary data for us to power a larger study. So again, you can see the reduction in visceral fat in the control group, but not as much of a pronounced reduction in fat in the alcohol group. Okay, and so for the Consume 2 study, this is us moving, in a different direction, kind of expanding. Again, the first grant was in women only, and so we wanted to look in men and women. And then in the first study, we still wanted to be a controlled study, and a few of the details that, I need to mention. So the food consumption was controlled in that we provided all the food, and then the alcohol consumption was also controlled. So we provided the alcohol. Yes, our pharmacists had to go to the grocery store and buy bottles and bottles of alcohol. And the pilot study was actually spirits only. So they could switch up, because based on calories, as long as there were a similarity. So if they wanted to do tequila one week and gin the next week and then whiskey the next, they could do, whatever they wanted to do. And they just told us their preference, and they had to mix the alcohol with non-sweetened mixers, because again, we want to match everybody via that macronutrient composition to where the only difference was the alcohol. Then for the pilot study, because we didn't really have any preliminary, it was a pilot study. And so for that study, we did 2.5 drinks, okay, per day, 2.5 shots, right? So for some of you, you didn't even bat an eye, like, oh, okay. But, if you think about it, that's beyond, what the recommendation is in terms of alcohol. But what happens is, people say, oh yeah, I only drink one drink a day. And I'm like, okay, well, what's your one drink? Well, something like that, that's not a drink, that's several servings. And so, we just wanted to be as controlled as possible in that. So we actually measured, to a T the exact amount. And I mean, we had so much oversight in terms of safety, and oversight to make sure, that they were drinking the alcohol, as instructed, and then making sure that nothing, happened in terms of side effects. Everybody who enrolled in this, they were all drinkers. So it's not like we were bringing in people who had never drank alcohol before. And then before they could be enrolled in the study, they had to do what we called an alcohol tolerance test, where we had to sit on Skype and watch them drink the alcohol and then sit there and watch them for like 2 hours to make sure that they didn't have any side effects. So again, it was women only. For me, it was fine. We could have great conversations, but my poor colleague, John, like having to sit there and watch a woman for like 2 hours, because it was the evening time. So they couldn't be, at work. They had to have finished all their activities for the day. And so, they're like, oh, well, do you mind if I move from the living room and sit on my bed? Okay, sure. I mean, but anyway, we did whatever we could to ensure that we dotted our I's and crossed our T's for that study. So we had no safety issues and no side effects for that study. And so for this study, we want to do something similar, but instead of the 2.5 drinks a day, again, because this study would involve men and women, we actually want to make it to be a percentage of their energy needs. So everybody would get 10% of their energy needs in alcohol. So that way it makes it level, depending on BMI or whatever, it makes it level across the board. And again, we expect between 5 and 7% weight loss. And then we're going to look at a variety of cardiometabolic health outcomes, as we did in the pilot study, looking at abdominal fat, blood pressure, circulating lipids. And one additional thing we're doing for this is based on very limited recent data, very limited published data, is that alcohol can have an effect on fat oxidation. And so they're actually going to spend the night in the metabolic chamber so that we can get assessments of fat oxidation. Okay. And so then, oh, and I don't know why it's showing up like that. But anyway, those are the specific aims that we're using or that we submitted for the grant. And so it's not, I don't think I can edit it. But anyway, we submitted the grant for the first time. It did not get discussed. We submitted to NIAAA Institute, did not get discussed, submitted it again, 6th percentile. So, right, a hand clap. Not really, stop clapping, because they did not fund it. So I'm trying not to burst into tears all over again. But yeah, they decided that their direction for the Institute was different than this. This was different outside, kind of outside of the scope what they traditionally fund. And they opted not to fund it. So we are back at square one. We resubmitted to NIDDK. We just got our scores back about a week ago. Like 31 percentile or something like that, which isn't terrible. I mean, we're gonna go back in, but man, like a bummer. Like next to a labor and childbirth, like this probably hurt the most, like over over recent years. Like this is right up there. So anyway, we're gonna keep pushing. We think it's a great and innovative study, and so we're gonna continue on that trajectory to try to get it funded. Okay, and then I'm not talking in detail about these, but I just kind of wanted to mention a couple of other projects that I'm involved with. You guys are familiar with All of Us. This is also an All of Us site. We are also one of the clinical sites for the Nutrition for Precision Health, with Eric Ravinson and Leanne as the PI. So I'm also one of the co-investigators on this project. So, this is all about nutrition, precision nutrition, and looking at individual metabolic responses to various diets. So this will be a rich, data set, especially for people really interested in health outcomes and physiology. So we're excited, about this study and how it can move the field forward. And then I'm also committed to diversity in academia. So this is another U-level study that we have, U01, sorry, study that we have. This is Robert Newton and Peter Kay are actually the PIs on this grant. I'm a co-investigator and I'm also the director of the peer mentoring program, which is a component of the training grant. So the idea is just to make sure that we have a diverse competitive workforce and that we're giving everybody the great opportunity to obtain NIH level funding that can promote their academic success. Okay, and these are some of my, well, most of my collaborators. I don't think I left anybody off. My funding sources, there's Derek, he's my research associate in my lab. And with that, I'll take any questions. Thank you.
Good talk, by the way, thank you. Earlier in the talk, you mentioned like a distinction between like abdominal fat and like leg fat.
Mm-hmm.
I'm pretty familiar with like the distinction between like android and gynoid, but like, if you like looked at leg fat versus abdominal fat under a microscope, is there like a noticeable distinction between the two, or is it just mostly the location?
Yeah, so it's I mean, we know there are physiological differences. You know, it kind of depends on what you read, but one of the factors that has been shown to possibly be different is adipocyte size. So the femoral fat has more small adipocytes. That's what's been reported in the literature. Another characteristics would be differences in lipolysis. So the response to stimuli of lipolysis. The leg fats, you know, it's been reported that it's not as responsive to lipolytic stimuli, which is why, you know, in women you would see more of the pronounced, you know, thigh fat in that region. So that's compared to the abdominal. So those are the two things that really come to mind when we think about the characteristics. A lot of the literature focuses more on, because we say abdominal, but we know there's visceral fat, which is intra-abdominal, and then there's subcutaneous. So there's been more work in terms of the visceral fat and how it's bad for you due to its proximity next to the other organs and things like that.
Thank you.
Yeah.
Oh,
Thank you. Great talk. So I have a question about your alcohol study.
Yes.
So I know whenever I have a drink, my sleep is always rubbish in the evening. And disrupted sleep can have an impact on metabolic glucose control. Are you controlling for that at all? Like,
So you must have been one of the reviewers because we got that comment. And so the answer is no, we did not. We definitely should have thought more intentionally about the sleep component, and we didn't control for that. As a matter of fact, I don't think we discussed it at all in the grant. So definitely for resubmission, that's something that we'll consider. We will definitely consider because we know that alcohol can disrupt sleep. So
Would be the mechanism by which
it.
have less improvement.
Yeah, no, you're right. You're right. Yeah. And I think that's what they were getting at also. So we'll definitely try to monitor that in some way. You know, we won't be able to bring them to Pennington to monitor their sleep over, you know, over the time, but definitely included some type of assessment. I think we'll definitely do that. Thank you for that.
Yeah, so that's a fabulous question. I think so too. That could be really telling
Mm-hmm, mm-hmm.
what that does to metabolism.
Yeah.
So yeah, great talk, so much great work and so many great studies. So thank you for getting all that in there.
Yeah.
I have a question about racial differences. So I noticed in one of your early studies, you show almost split African-American white women.
Yes.
Do we know anything about racial differences in terms of how?
Yeah, so we did not see race differences in terms of adipocyte formation or hyperplasia. We definitely looked at, we didn't see. What we did see were differences in triglyceride formation. So we showed that white or Caucasian were more efficient at triglyceride formation versus blacks. So that was, it was one, and we did publish that paper. But in terms of racial differences, that's the only thing that popped. But it fits, you know, if you think about some of the comparisons, you know, that you see in blacks, you know, versus white or other races as it relates to insulin sensitivity. I mean, it makes sense. So, Yeah, but that's the only racial difference we've seen. But we also, we always try to account for that in all of our studies. So that's definitely an enrollment goal of ours to make sure that we stratify appropriately and we include, a diverse population. Mm-hmm.
Great talk. So I was curious about is it the E2 study?
Yes.
Weight cycle?
Yeah.
We know that during weight loss, you reach a point where the weight loss plateaus.
Yeah.
Are you gonna take into consideration the doing biopsy in like during the active weight loss and during the plateau?
Yeah. So the short answer would be we would love to do that if we had the money, but with budget, we just weren't able to include that. But it would have been fantastic to have one like right in the middle. But you're right. I mean, the best that we can do is the fact that we're tracking the weight over time. We will have those collections. So the best that we can do is use the data that we have and have that to be a consideration whenever we go to analyze the data, because we will have the body weight data. But yeah, it was a consideration, but we just couldn't do it due to monetary issues. Mm-hmm.
Dr. Lundy's last question.
This is kind of random, but I know we talked about microdialysis, but
Yeah.
and I saw a free living microdialysis on one of the X.
Which one?
It was the timeline that you had. I can talk to you after, but I'm just curious, what in the world is free living?
So it could, was was which study? Was it Hickner study?
Motor pack.
Oh, it was Atlas.
I feel like it said free living.
Instrument, maybe
Yeah.
instrumented with microdialysis.
I don't even remember that. Let me see.
I guess CGMS.
This one? No, sorry, now I'm taking everybody's time.
Oh, no, that's okay. Oh, wait, this way.
This one.
Yeah, free living microdialysis.
So I don't know what,
That's okay. 'cause
yeah, honestly, I'm not,
But that's good. I'm gonna look at it.
yeah, I mean, I'm not familiar with the different, because again, the microdialysis is happening on site in response to an acute exercise bout. So it's while they're exercising there, they're doing the microdialysis. So honestly, I'm not sure why that the free living component is included.
It's like free living
Mhm.
individuals versus.
Yeah.
But-
Mhm. Mhm. Mhm.
One last question.
Okay, sure.
The patients with lipedema,
Yeah.
are they at greater risk for metabolic dysfunction or cardiovascular disease?
No.
They're not.
So many times they are protected. And so, in a lot of ways, that's kind of, I guess that's why, some of them have articulated that maybe that's why they get these feelings of being like dismissed, like, or they get that perception of dismissive, because yeah, many times they're still metabolically healthy.
Yeah, so
So-
the reason to study would be more for cosmetically, of course.
Yes.
Mobility.
And then the pain, yeah, definitely the pain. Actually, for the Obesity Society, we had our first ever symposium session on lipedema, and it was very interesting and informative. So part of the panel was a person living with lipedema. She had lived with it for years. Like she actually had it since childhood, and she was able to talk about like all these experiences that she had growing up, not only being, having obesity, but she had a sibling. And so relative to her, sibling that did not have lipedema or obesity, and just the things that she experienced along the way, even her path to being diagnosed. And that was one of the things, because she's not diabetic, she didn't have hypertension, cardiovascular disease, any of that. So that was part of the challenge, was getting someone to notice, because she didn't have those things. So, that's true. Thank you. Thanks, everyone.